Morning, this is Advanced Patient Care Theory 2, Unit 3, Part 11, Assessment and Management of the Elderly. So again, just a bit of a quick overview of some issues with the elderly in terms of assessment and management of starting with altered level of awareness or altered mental status. So in terms of strokes, we know a high percentage of the elderly experience strokes at 80 or 85% of stroke victims are elderly, rather, not necessarily that a high percentage of elderly experience strokes. And oftentimes, we see them when they've had a stroke in the past, not necessarily acutely, and it affects not just their personal identity, but affects a lot of functions: swallowing, eating, communicating, and so on and so forth. And they have, elderly have less of a physical and psychological reserve to cope with illnesses such as strokes. Risk factors for stroke include hypertension, probably the biggest one, chronic systemic hypertension, and leading to cardiovascular disease. History of TIAs puts them at high risk for stroke, atherosclerosis, diabetes, high cholesterol. So in terms of assessment, we do the usual ABCD and evaluate blood sugar in anyone with an altered mental status. We have to look at meds, drugs, and alcohol to see if any one of those is a cause or contributing factor to their altered mental status. And narcotic overdoses, not uncommon in cancer patients. Hopefully fire and police won't arrive before we do and whack them with a full 4 milligrams of intranasal Narcan and put them into excruciating pain. Hopefully we can get to them first. We want to evaluate for trauma. This is really important because a lot of elderly sustain trauma and have no recall of a fall or an incident, or maybe being physically abused by a family member or by health staff. And I tell my PCP students, if they're spending time in a nursing home, I give them a list, sort of a treasure hunt of things to look for. Some obscure things, but some not so obscure. So, to look for pulsus paradoxus and carotid bruit, but also, look at mastoid processes. And almost every time there's at least one student who's found someone who's got unilateral or bilateral mastoid bruising or periorbital ecchymosis from a fall that went unnoticed, or they just did nothing about. So we want to evaluate for stroke, other metabolic disturbances. In terms of the cardiovascular system, there's going to be changes in the elasticity of the large arteries, which means there's going to be increased peripheral vascular resistance in most of the elderly, with systolic and diastolic hypertension. As a response to chronic systemic hypertension, the left ventricle starts to enlarge or hypertrophy, and eventually it begins to fail. So initially that's a compensatory response, but eventually that begins to fail. And we've all heard that expression, hypertension is a silent killer. But if you've got a parent, for example, who's most of you have parents who are probably my age, but who doesn't see the doctor. You might want to take the time and check their blood pressure, because people will go for years without knowing that they're hypertensive, and then things start to deteriorate very rapidly. MIs and strokes and so on. So as we get older, we have less of an ability to maintain cardiac output with heart rate. At the other extreme, children, their primary mechanism for maintaining cardiac output is heart rate, not the force of contractility. In the elderly, it's just the opposite. So heart rate, they may not be able to maintain cardiac output based on heart rate, especially if they're beta blocked, right? So they may not be able to mount a tachycardia or anything beyond maybe 110 or so for compensation. Other changes. So less blood enters the left ventricle passively. If you recall from last semester, we talked about how when blood returns to the atria via the vena cava and via the pulmonary veins, that that blood in the atria just enters the ventricles, and the ventricles fill to about 70% of their volume until they before the atria then contract, propelling the remaining 30%. So there's less passive filling. As a consequence, there's a higher dependence on atrial kick, and this is a problem because atrial fibrillation is the most common arrhythmia in the elderly, and they lose that atrial kick. Now, you would think, well, if the atria contribute about 30% of stroke volume, that their cardiac output would be diminished by about 30%, but in fact, cardiac output's diminished maybe by 10 to 15% in AFib in most cases, just simply because where they lack that atrial kick or that added volume to the stroke volume, they typically compensate with an increased heart rate with AFib. The elderly are more likely to have dysrhythmias, and it becomes a bit of a challenge to distinguish between, what's a chronic versus a acute ectopy. So, someone who's got a trigeminy like this, it might be just a chronic thing. Maybe it's unfair to call it trigeminy because we don't see enough of this, but there's a fair bit of ectopy here. This may be a chronic thing, in which case, we don't even worry about it. So, we look for changes in their either drugs or metabolism or their metabolic state to see if something's causing cardiac irritation. They may also be dependent on cardiac pacemaker. And the pacemakers are pretty sophisticated these days. They may respond by increasing the firing rate based on respirations, based on movement. They used to work on a pure accelerometer, and I remember 25 years ago when there were issues with people with sort of the newer model pacemakers with accelerometers, where if they boarded a plane and took off, the accelerometer would sense the speed and would increase their heart rate. So these older people would be having like raging tachycardias on an airplane or in a car that was accelerating. I don't think that was a big issue, but I just thought that was kind of an interesting thing. Sorry, for some reason my slides are delayed here. Stand by. Let's see if we can get these slides advancing. For some reason, they're not. The slides are not coming up at all. I'm going to just reload these slides. See if I can do that. Stand by a second. Looks like we're back in business here. Okay, so continuing on with cardiovascular changes. So lots of diseases affecting the cardiovascular system, including hypertension, diabetes, atherosclerosis. Lifestyle factors, a major impact. Just curious, how many of you have had patients who are VSA within a year to 2 years post-retirement? I've seen it quite a bit, personally. Yeah, okay. So with that in mind, I think it's important to prepare for activities in your retirement. For the last couple of years, I've been thinking about what projects I'm going to take on when I retire, so I'm not completely sedentary. Because this is what happens: is there's a very sudden change in lifestyle with retirement, and very quickly people deteriorate either cardiovascular disease, respiratory disease, or end up going into cardiac arrest. And that's not a good thing. So you guys are all really young, and if you got parents who are approaching retirement, without scaring them and telling them that you encounter a lot of people who die in the first year to 2 years post-retirement, you might want to have a conversation with them about planning for retirement, and just explain that going to a sedentary lifestyle very quickly is not a good thing for their health. So sedentary lifestyle, obesity, alcohol use, poor diet. I keep joking, I'm not much of a drinker. I do like have beer when I barbecue in the summer, but I drink very little, and so like 1 beer and I'm a little woozy, 2 and I'm table dancing, 3 and I'm in a coma. But I keep joking with my wife and with my friends that when I retire, I plan to drink a lot more. But that's one of those things I say somewhat tongue in cheek, but I do plan to drink more. But I'll have to be careful about that. Smoking an issue as well, obviously. In terms of respiratory systems, so they're slow, subtle changes over the years, and they actually begin as early as age 30. And there's over time decreased chest wall compliance, loss of lung elasticity, air trapping. Interesting thing, if you want to keep your lungs healthy, one of the things is exercise. But I learned a couple of years ago something that actually would keep your lungs even healthier is playing the tuba. So there you go. Functional reduction in vital capacity up to 50% by the age of 65. That's pretty significant. With time, in the elderly, you see decrease in cough reflex and decrease in cilia activity, which puts people at higher risk for pneumonia and recurring infections. And other factors include affecting pulmonary function include things like kyphosis. I don't know if I told you the story about I had a lady with in the hospital with kyphosis, and I had to intubate her, and the respiratory therapist said that's going to be a difficult intubation, and I said, how come? And he said, because she has kyphosis. And I said, are you sure, or is that just a hunch? Ha ha ha. Okay. I probably cracked that joke last semester. Chronic exposure to pollutants with age is a problem. Long-term smoking, disease processes. So here's a classic call, and you tell me what's going on here. This will probably be easy for you guys. You respond to a 78-year-old male who's quote unquote unwell, and the daughter tell you he hasn't been himself for the past week. He lives at home. He lives on his own. He normally walks to the corner store every day and to the local recreation center twice a week. And on assessment, he just appears tired, no recent cough or fever. He denies any shortness of breath. When you listen to his chest, you hear good air entry bilaterally, and that's clear to the basis. And here is vital signs. So what sticks out for you, and what would you put at the top of your differential diagnosis, given the limited sort of history you have in his vital signs? Thoughts? Yeah, so UTI might be in there, but it's maybe not so high on the differential diagnosis. His temp is normal, but the one thing that stands out is he's got a low SAT, right? An unexplained low SAT, and you can presume he's not a COPD because I didn't mention it, but medication change is fair enough. But the one thing that stands out here is that he's got a low saturation, and unexplained low saturation. And in a guy who's feeling generally weak and a low SAT, pneumonia is really high up on your differential diagnosis. So unexplained general weakness with a low SAT. In terms of hearing pneumonia, that classic bronchovesicular sound that you might auscultate, not likely you're going to be able to find that. You would have to auscultate in 20, 30 areas in his lungs to try to find that area. Sometimes pneumonias occur in the perihilar region, so I'll listen at about the fourth intercostal space sternal border on both sides to see if there's anything there, but you may not pick up on that. But when you get someone who's older, general weakness with a low, unexplained low SAT, pneumonia should be high up on your differential diagnosis. That'd be the key. Okay, hang on a second here. In terms of skin, the integumentary system, so with age there's going to be increased dryness, roughness, wrinkling, reduced replacement and repair of cells. That leads to longer healing times, and there'll be reduced subcutaneous fat as well, and that has implications in terms of heat loss and heat gain in the elderly, and combine that with decreased function of their hypothalamus, their thermoregulatory center. They're at higher risk of hypo and hyperthermia. Reduced protection of the body from trauma, and there's an increased incidence of decubitus ulcers in bedridden patients, and pressure sores can develop in as little as 30 minutes when they're placed on the backboard. Another reason to avoid the backboard or get them off the backboard fairly quickly. And they can get pressure sores in areas that you might not suspect, like the nares from nasal prongs. Now that's not generally a pre-hospital issue, but when they've been in hospital for a while, they can get pressure sores in their nares or they can get them around the mouth for endotracheal tubes that are placed with pressure up against the lip. And there's a higher incidence of malignant and benign tumors in the elderly. In terms of GI system, there may be reduced taste sensation. Sometimes I wish that was the case for me, because I would love to not crave food and not be as passionate about food as I am. I remember my wife's uncle, he and I were out golfing one day, and it was about an hour away from dinner. And I said something about how I was looking forward to dinner, and he said he wasn't. He was, I think he was 65 or 66, and he said to me, I've been eating my whole life. I'm tired of eating. I'm bored. I don't enjoy it. And I thought, boy, I wish I felt that way. That would be nice. Be a good weight loss thing. So loss of teeth and impaired chewing, puts them at risk of foreign body obstruction, higher incidence of GERD. Of course, past stroke puts them at higher risk of foreign body obstruction as well. Higher risk of peptic ulcer disease. Interesting. I don't know about you, but I see far less issues with patients on NSAIDs having GI bleeds now than I did 10, 15 years ago. That was a common thing. People on chronic NSAIDs for arthritis would have GI bleeds. There's an increase of risk of mesenteric infarcts in patients with a history of chronic atrial fib. So what happens with atrial fib, even though they're anticoagulated, you still get microclots, and they travel to the brain, the lungs, the GI tract, and you can get small infarcts in the mesenteric vessels, and that can be enough to cause an ileus, so an impairment in peristalsis, and lead to a bowel obstruction. So if you got someone with a GI obstruction like symptoms, and they've got a history of chronic AFib, there's a good possibility that's the cause. Higher incidence of fecal impaction and diarrhea. Have any of you watched a fecal disimpaction in your clinical or past clinical as a student? Yes, no? No? Okay, so not the kind of thing you want to stay and watch anyway, but it's interesting. A few years ago I had this romantic notion about being a community paramedic and thought that might be a nice thing to do as I get older as a medic. And then I listened to this podcast. I think it was the ER podcast with Dr. Rob Orman, and it was called and you can look it up. It's the title of the podcast is what is it now? What is it? Let me think. It'll come to me. But anyway, it was the Constipation Manifesto. That's what it was called. The Constipation Manifesto. So if you look it up, it's a pretty funny podcast, and they talk about basically fecal impaction, and mostly it's physicians who do it, and on rare occasions some physicians will delegate to nurses. But it's amazing, after all these years and all the advancements in technology, you would think that a physician, an engineer, and a plumber would get together and figure out how to disimpact people. But basically what it comes down to when meds don't work is just you put 2-3 pairs of gloves on, you stick your fingers up the butt, and you slowly chip away piece by piece at this hard piece of poop until it starts to break apart and it all comes out. You'd think they would have sorted all that out, but anyway, my idea of community paramedics was definitely altered after listening to that podcast, because I thought, this could become part of a community paramedic scope of practice. But physicians say it's one of the most satisfying procedures you'll ever do, because the patient is in so much pain, and when you finally break it apart and it starts to come out, the relief is indescribable. So anyway, not my cup of tea, but and of course there's a higher incidence of narcotic constipation, especially people who've the elderly who've had a recent procedure and they're on maybe Tylenol 3s with codeine, and narcotics are known to cause constipation and fecal impaction. In terms of hepatic and endocrine function, changes to the liver, there's a decreased hepatic blood flow with age, decreased hepatic weight and function, and that means decreased ability to metabolize and eliminate some drugs, detoxify some drugs. And some medications can cause liver failure over time, especially people who are inadvertently overdosing with Tylenol, unaware that it damages the liver. Some endocrine changes, maybe metabolic changes. Hyperglycemia is common. Undiagnosed diabetes, not uncommon. Poor nutrition and low calorie intake, development of diabetes, as I mentioned. In terms of temperature regulation, you all know firsthand what an issue this is, because you go into someone's house that's sitting at 38 degrees Celsius and they're wearing sweaters and shivering while you and I are melting, and so they're susceptible to variations in environmental temperature. So diaphoresis only occurs at higher temperatures than some of the elderly, and so they don't have that ability to evaporate or dissipate heat. Their autonomic nervous system response may be diminished, causing a decrease in shivering, and certain medications and pathologies can limit the response to extreme temperatures. In terms of renal, genitourinary issues, reduction in they have a total reduction in the number of functioning nephrons, so maybe decreasing kidney function. Reduced renal flow can be as high as 45% in the elderly, and so they may have increased waste production in the blood. If you've ever had a patient on hang on a second there, we lost the internet connection. There, we're back again. If you've ever had a patient on dialysis, you may notice they have Parkinson-like shakes, and that's just an azotemic peripheral neuropathy from waste products that aren't getting eliminated. So they're at greater risk of dehydration, and glomerular filtration can be decreased by as much as 50% by age 90, which affects their ability to excrete medications, and so what would normally be therapeutic is now toxic. Micturition syncope is common in the elderly. I always say if you're a man and you're 40, you should be sitting down to pee, especially at night, because micturition syncope is more common in men, typically when they get up to pee in the middle of the night, and then they fall, they hit their head. Sometimes they're unconscious and up against the bathroom door, and you and I can't get at them. Just out of curiosity, I've actually only had a couple of patients who syncopized and were up against the bathroom door. Have any of you had any patients who had an LOC in the bathroom and you couldn't get into the bathroom because they were up against the door? VSA against the door, yeah. Yeah. Scott, what did you guys end up resuscitating this guy when you got access, or did you just call for a pronouncement right away? Mm. Yeah, OD's leaning against the door. Okay. Yeah, I've had some syncopes and some VSAs up against the bathroom door. I had one guy who he was actually sitting in the doorway up against the door frame, so he wasn't blocked in, and he was VSA. That was kind of a blessing in a sense. So trips in the bathroom at night can also lead to falls and head trauma, and there's a high risk of urinary tract infection in the elderly, and that can lead to delirium or sepsis, and lots of different things that can contribute to incontinence. In terms of musculoskeletal systems, so there's typically a loss of height by as much as 2 to 3 inches with age, osteoporosis, kyphosis, decreased muscle mass, especially with people who are sedentary, increased susceptibility to falls, more serious fractures from simple falls, and one of the most amazing fractures I ever saw, not because of the fracture, but I had a lady in her 70s who ironically was walking down a spiral staircase and fractured her mid-shaft femur, and it was a spiral fracture, and she had maybe 1 out of 10 pain, which was quite amazing. You could see the upper leg was obviously deformed, and we put a Sager on her, transported her, but she just had minimal pain. In terms of assessment of LOA, sorry, this is all backwards here. Let me just load it all in here. So we want to assess the airway carefully, and just remember that dysphagia is common. Dysphagia is also common post-stroke, and that can lead to obstruction and aspiration. Lung disease and infection is common, so always get an SpO2 before O2. Pneumonia is common, and it may present without cough, without fever, without adventitious lung sounds, just a low SAT and general weakness. And in the elderly, depending on the age and comorbidities, it can end up being a terminal event. So you've got to be aware of alert for sepsis. Cardiovascular disease is common. Very common to see patients who've had old inferior wall MIs and have no idea they've had old inferior wall MIs because probably just experienced some indigestion and general weakness some years ago, and we see pathological Q waves in the inferior leads when we do an assessment. And neuro requires some attention to detail, looking for not just global deficits but focal neurological deficits as well. So in terms of meds, we know they're on a buffet. We have to be careful that we're not looking at a list of meds that are old meds that they're no longer taking. But we want to get some idea of whether they're taking them appropriately at appropriate intervals and appropriate doses. And if they've, I think patients who have their meds in blister packs, that's a good thing that the pharmacy does that, because, if you're on 8 or 10 meds and you have to take them out of the bottles and put them in your own plastic containers, it's so easy to make a mistake. Leave a drug out, put 2 drugs in instead of 1. So I watch for those. The plastic containers I'm talking about, they buy at the drugstore and they fill themselves. That's always risky. So unfortunately, we don't have the time to go through those and see if they got the drugs mixed up. So impaired renal and hepatic function can lead to toxic levels of drugs, and we need to know the drug classification so that we can look at 12 meds and know exactly what conditions that patient is on. If you're going to do blind nasotracheal intubation, you got to make sure they're not on rivaroxaban or warfarin, some other anticoagulant, right? Because that's, according to your base hospital, that's a contraindication. So the meds will identify the medical history. Important to pay attention to what's seen to be benign symptoms, because that can be much more serious than we think. We want to rule out shock and hypoxia, and monitor SpO2, O2, PRN, ECG, consider 12 lead. I would consider 12 lead even in syncope. That's sort of departure from the medical directive, but I think you can justify that. And just remember that MIs can be vague or have misleading symptoms. There's, women and chest pain seems to be coming up in the media and in the literature more often these days. How there's a medical bias, and that we're missing women with MIs. So I think it's important to be diligent about doing cardiograms in women who have vague-like symptoms, and not necessarily just older women, but women in their 40s and 50s who have any vague systems like weakness in the arms, or nausea, mild shortness of breath without any chest discomfort, those sorts of things. With the elderly, we have to think about what's acute, what's chronic, and are we dealing with acute on chronic? And of course, we know that refusals are common, and I'm going to respect those refusals if I absolutely have to. But if I genuinely think someone needs to go to the hospital, I'm going to do my best to persuade them. It would be nice, actually, if we could refer some of the elderly to a community paramedic program. Now, just curious, in Toronto, do you have that ability? If someone refuses care in the community, can you send a community paramedic over to see them, or any other service? Tell me where you work again, Mackenzie. In Dufferin. That's fantastic. That's really great. You refer them to Sync too, but it's not the same day, right? Okay, yeah, that's unfortunate. Yeah, that's interesting, Mackenzie. Was that the Minister of Health who came, or was that a deputy minister or someone? Yeah. I think that's the kind of system we need, is the one like in Dufferin where, if you have a refusal, there'll be a follow-up, and you can say to the patient, look, another paramedic's going to come by here in about an hour, 2 hours, check up on you, make sure you're okay. Are you all right with that? Your chief put on a clean shirt. I'm sure he wears a clean shirt every day. I know your chief. He's a clean shirt kind of guy. Okay. Very cool. So again, remember, there is some research that supports the notion of contacting a physician and putting the patient in on the phone with a physician. Interesting, the 3 calls that I've had where the patient genuinely needed medical attention and refused, and I contacted a base hospital physician. In all 3 cases, they still refused. But at least I'd done my due diligence. When I got the base hospital doc back on the phone, he said, because it was a he each time, he said, Rob, we both did everything we could, just document it well, and call me back if you need me. So, that worked out, unfortunately. This is an old article from Florida in the early days, I think, when Viagra first came out. There was an increased incidence of sexually transmitted infections in the nursing homes. Hysterical. You find a lot of elderly patients now a lot of elderly men on Cialis for benign prostatic hyperplasia. I don't know if you find that in the region where you work, but where I worked, it seemed like all of a sudden all the men were on Cialis. And I thought, what the heck is going on here? But then I learned, I didn't know, but it was being prescribed for enlarged prostate. So that was interesting. Any questions about sort of overall management of the elderly and elderly conditions? Okay.